So, in patients with the rheumatoid arthritis, the basic problem, the main concern is pain. So, the pain of joints, right? So, for the pain, we have NSAIDs. These are non-steroidal anti-inflammatory drugs. These are given for only pain, okay? And these NSAIDs, they only provide symptomatic relief, but there is no effect on the progression of the disease, okay? And coming to the acute phase in the rheumatoid arthritis, we have corticosteroids. And we have another group of drugs, that is DMARDs, which are disease modifying anti-rheumatic drugs. These drugs, they slow down the progression of the disease, and these are considered as a drug of choice in rheumatoid arthritis. These drugs take 6 weeks to 6 months to stop the progression of the disease, okay, to start the effect. Coming to the classification of the drugs which are used in the treatment of rheumatic arthritis, we have NSAIDs, corticosteroids and DMARDs. Coming to the NSAIDs, these are given for the acute pain. They reduce the pain, okay. Coming to the corticosteroids, these are used as a bridge therapy to reduce the disease activity. Coming to the third group of drugs, which are DMARDs, these are classified into two groups, that is synthetic and biological. Coming to the synthetic, we have Methotrexate, sulfasalazine, leflunomide, hydroxychloroquine and minocycline. And we have tofacitinib, gold salts, and the last one, which is penicillinamide. Coming to the biological, we have four groups in biological, that is Tnf Alpha Inhibitors, co-stimulant inhibitors, interleukin 6 inhibitors and B cells depleters. Okay, coming to the Tnf alpha inhibitors, we have etanercept, infliximab, adalimumab and golimumab and setolizumab. Coming to the co-stimulators, we have abatacept and belatacept. Okay, coming to the interleukin 6, we have only one drug, that is tocilizumab. Coming to the B cell depleters, we have rituximab. Okay, so now let's discuss in detail about the synthetic DMARDs. So the first drug of choice in synthetic DMARDs is Methotrexate. It is a drug of choice in the rheumatoid arthritis, and it is used as an anti-neoplastic drug which is used in the cancer chemotherapy. And this Methotrexate is used in the lower doses in the rheumatoid arthritis, that is 7.5 milligrams once weekly. In case of cancer chemotherapy, it is used as 30 milligrams daily. Okay, coming to the adverse effects, it causes the gastric irritation and stomatitis. And the patients who are taking this Methotrexate causes the hepatotoxicity in the form of fibrosis and cirrhosis. And the risk factors include, it causes hepatotoxicity in patients with chronic hepatitis and heavy alcohol consumption, and in patients with diabetes mellitus, and patients who are obese, and patients with kidney problems. So coming to the side effects, we have Methotrexate, right? Taking Methotrexate increases the risk of B cell lymphomas, and taking Methotrexate causes a suppression of the bone marrow and causes the pancytopenia, that is deficiency of the cells, red blood cells, white blood cells and platelets. Okay, and Methotrexate also causes the hypersensitivity reaction, that is interstitial pneumonitis. And when a pregnant woman takes Methotrexate, it causes the teratogenicity, that is in the fetus there will be structural abnormalities. Okay, so coming to the drug interactions which increase the Methotrexate toxicity, we have ampicillin and probenecid. This is due to these are the two drugs which increase the Methotrexate toxicity, because these are due to the same transporter system in the proximal convoluted tubule of the nephron in the kidney. Okay,